When a patient is tachycardic in the cardiac ICU, one of the first questions we ask ourselves is it sinus? While we are taught to look for a P wave before the QRS, infants can get their heart rates up really high, even over 200 when they are crying, making it hard to see if a P wave is there. That's where atrial electrocardiograms, atrial ECGs, come in. This can only be done if your patient has temporary atrial pacing wires, so this only works in the postoperative patient. With an atrial ECG, the P wave is being read directly from the wall of the atria, not through the chest wall like a standard ECG, so the P wave is exaggerated and much easier to see. The top tracing is from a surface lead showing small P waves below the QRS. In the atrial tracing on the bottom, the P waves are nearly as big as the QRS. There are a few ways to do this. The fastest and cheapest is to take the end of an atrial pacing wire and stick it under one of the telemetry leads. You should then see bigger P waves on the monitor. But this doesn't always work, and sometimes our electrophysiology friends want more information than this gives. The next option is to bring in the ECG machine and hook it up to the patient. You then take the end of the atrial pacing wire and attach it to one of the alligator clips and run a rhythm strip. You can then compare the lead with the atrial reading to the surface leads to determine where the P waves are. My preference is to only use the limb leads and attach the right arm lead to the pacing wire, because it gives me what I need without anything extra. But I think my EP friends hate this because they want all the information that a full ECG gives. There is also a device on the market that provides a continuous atrial tracing on the monitor so changes in rhythm can be seen in real time. But to keep this channel free of commercial interest, I'm not going to tell you what it is. Now that you have your atrial ECG, let's interpret it. For sinus rhythm, you will see a large P wave before each QRS. But be careful. Not all P waves come from the sinus node, so not all rhythms with a P wave before the QRS are sinus. The most you can actually say in this situation is that the rhythm is atrial. This could be atrial ectopic tachycardia, and you will have to use other clues to decide which it is. Here's an example of sinus rhythm with a blocked ectopic atrial beat, called a blocked PAC. This P wave is not coming from the sinus node, but it looks a lot like the P waves from the sinus beats. Here's an example of a rhythm that is definitely not sinus. Do you see the P waves? The P waves are coming behind the QRS. These are called retrograde P waves, and they are not coming from the SA node, but the AV node. In junctional ectopic tachycardia, JET, the AV node is firing fast. The electrical signal goes down to the ventricle and triggers a QRS, then up to the atria and triggers a P wave. Nothing else really looks like this, so if you see retrograde P waves, the patient has JET. How about this one? There are P waves. They don't seem to have any relationship to the QRSs. This patient has AV dissociation, where the atria and the ventricle are not talking to each other. This patient also has junctional tachycardia and may have heart block. This is JET because the QRSs are faster than the P waves, and the AV node has taken over as the pacemaker of the heart. Compare this to AV dissociation with the junctional escape rhythm, where the P waves are faster than the QRS because the AV node has taken over, as it is no longer getting a signal from the atria because of complete heart block. Here's another atrial tracing. There are no P waves. We have two options here. One is that the pacer wires are no longer attached to the heart, which can happen. But I can pace this patient, so I know that they are still there. So the SA node isn't doing anything at all. The QRS is narrow, so this is a junctional rhythm. SA node dysfunction can happen after cardiac surgery, and we expect the P waves to return as the patient recovers. The last tracing I want to show, I don't actually have an example of, but it's something like this. Fast, narrow QRSs with 2 or 3 P waves between them at regular intervals. This is atrial flutter with 2-to-1 conduction through the AV node. Thanks for watching. If there are any other CICU topics you would like to see videos about, please leave them below in the comments.